Today, today we will look into demyelinating and degenerative diseases of CNS. In part 1, we will focus on demyelinating diseases of the CNS, and in part 2, we will look into degenerative diseases of CNS. We will focus on the clinical pathological features of multiple sclerosis, Alzheimer's disease, and Parkinson's disease, and we will briefly discuss on motor neuron disease and spinocerebellar ataxia. Demyelinating disease are acquired conditions which tend to damage myelin but preserve the axon. So the clinical features are due to primarily myelin loss on the transmission of electrical impulses along the axons and secondary damage to the axons. This is due to the CNS limited capacity to regenerate the myelin. About 1 in 1,000 people in the United States and Europe are affected by demyelinating disease, and about 80,000 people in the UK have multiple sclerosis, which is the most common demyelinating disorder. Most of the myelin-associated diseases are acquired diseases and can be caused by infections, autoimmune disorders, or metabolic disorders. Multiple sclerosis is an autoimmune demyelinating disorder. MS is characterized by distinct episodes of neurologic deficits that are separated in time, i.e., there must be at least 2 episodes separated by at least 1 month. And it is due to patchy white matter lesions that are separated in space, which is defined as the location of the lesions must be in at least 2 distinct sites in the CNS. The disease may become clinically apparent at any age, although the onset in childhood or after 50 years of age is relatively rare. Women are affected twice as often as men. In most individuals with MS, the clinical course takes the form of relapsing and remitting episodes of variable duration, marked by neurologic defects, followed by recovery of the neurologic function. The frequency of relapses tends to decrease over time, but there is steady neurologic deterioration in most affected individuals. As in other autoimmune disorders, the pathogenesis of this disease involves both genetic and environmental factors, but it is not well understood. The incidence of MS is 15-fold higher when the disease is present in first-degree relative and 150-fold higher with an affected monozygotic twin. Environmental factors are also important. There is a geographic variation in the prevalence of MS, whereby there is a higher number of cases diagnosed away from the equator. This has been proposed to be related to a low level of vitamin D in people who are not exposed to sunlight during the winter. The available evidence indicates that the disease is caused by a cellular immune response directed against the component of myelin sheath. This response is initiated by T helper 1 and T helper 17 T cells that react against myelin antigens and secrete cytokines. The T helper 1 cells secrete interferon gamma, which activates macrophages, while T helper 17 cells promote the recruitment of leukocytes. The demyelination is caused by these activated leukocytes and their injurious products. How the autoimmune reaction is initiated is not well understood. A role of viral infection has been proposed, but this remains controversial. Here we can see that the white matter contains this irregular area of gray gelatinous plaque of discoloration, pointed by these arrows. This picture shows another plaque or demyelinated lesion, and these plaques have firm consistency compared to the surrounding white matter. This is the histological view of the plaque. As you can see, these areas are not taking up the blue stain of Luxol Fast Blue. This means that these areas are demyelinated. This slide shows the histological finding of MS in active demyelinating plaques. It looks very cellular because of the presence of lipid-laden macrophages. You can see the clear cytoplasm of the macrophages. In the second picture, if there is myelin, it will be staining blue. Now, there is lack of myelin here. And here you can see the preservation of the axons seen as this brown color on immunostain. So there is relative preservation of the axons. MS is a relapsing and remitting disease. Although MS lesions can occur anywhere in the CNS, certain patterns of neurologic symptoms and signs are more common. Three characteristic common presentations are optic neuropathy or optic neuritis, brainstem demyelination, and spinal cord lesions. Unilateral visual impairment due to involvement of the optic nerve is a frequent initial manifestation of MS. Involvement of the brainstem produces cranial nerve signs like ataxia, nystagmus, and internuclear ophthalmoplegia. And spinal cord lesions give rise to motor and sensory impairment of the trunks and limbs, spasticity, and loss of bladder control. There are only few other neurological diseases that have similar relapsing and remitting cause. The diagnosis of MS requires two or more attacks affecting different parts of the CNS. As we said before, separated in time and space. History and support from investigations, particularly MRI, make the diagnosis. When taking history at the time of initial presentation, it is essential to ask about previous episodes of neurological symptoms, often years previously, that may represent episodes of unrecognized demyelination. This slide shows the MRI picture of the patient with MS. You can see there's multiple whitish spots that represents the plaque, and you can compare it with the normal MRI. Examination of the cerebrospinal fluid in patients with MS shows mildly elevated protein levels, and this is shown here. You see, this is the investigation of the protein levels in the serum and the CSF, and this is from the normal person. You can see in MS, you can see these bands that are increased in the CSF, and this represents the oligoclonal IgG bands, and it is due to proliferation of B cells within the nervous system, which is postulated to be reactive. Treatment of MS consists of several types of immunosuppressive agents, which may slow the progression of the disease, but are not curative of the disease. For example, beta interferon reduces the number of inflammatory cells that cross the blood-brain barrier. There are also general measures and supported treatment for MS patients. Now we look at other demyelinating disease. The first one is neuromyelitis optica or DIVIC disease. Neuromyelitis optica is a syndrome with synchronous bilateral optic neuritis and spinal cord demyelination. It is often characterized by the presence of aquaporin 4 antibodies, which appear to be pathogenic. Areas of demyelination show loss of aquaporin 4. Within the damaged areas of white matter, there is necrosis, inflammatory infiltrate, and vascular immunoglobulin and complement deposition. The second demyelinating disease is acute disseminated encephalomyelitis, which is a diffuse monophasic demyelinating disease that follows a viral infection or a viral immunization. Symptoms typically develop 1 or 2 weeks after the event and include headache, lethargy, and coma. The clinical course is rapid, and as many as 20% of those affected die. The remaining patients usually recover completely. Acute necrotizing hemorrhagic encephalomyelitis is a demyelinating disease preceded by a recent episode of upper respiratory infection. This disorder shows histologic similarities with ADEM. However, the damage is more severe. There is presence of necrotizing venulitis with perivascular hemorrhage, diffuse ischemic lesions, and myelin destruction, and the disease is fatal in many patients. Central pontine myelinolysis is an acute disorder characterized by loss of myelin in the base of the pons. It arises 2 to 6 days after rapid correction of hyponatremia and is clinically known as osmotic demyelination syndrome. Rapid increases in osmolality damage oligodendrocytes. Inflammation is absent from the lesions and neurons and axons are well preserved.